Working now. Okay, so thanks again, Ting Nam and James, for the kind invitation to this workshop. So my talk today will be covering the image enhanced endoscopy in the lower GI tract. So I'm Louis Lau from CHK. So my disclaimers. So I would like to start with some basic concepts. So about the image enhanced endoscopy and also how we approach the diagnosis. So in fact, we all need to know what exactly is image enhanced endoscopy. So there are basically two major types. So what we are talking about MBI, BLI are those virtual chromoendoscopy. So they make use of some optical techniques in producing the light filters to enhance the differences between normal and abnormal. And traditionally, we rely on the dye-based boy, in fact, but with the good use of this technology, then we can switch over to the virtual one. So, but still, we have some good use of the dye-based, especially when we come into the endoscopic resection. We need to determine the margin. So for the dye-based, there are mostly two major types of the dyes. So most of the dye are actually absorptive. So essentially the cells will absorb the dye and then produce the color difference. Very typically is the iodine, the glucose solution in the upper GI tract. But in the lower GI tract, we will usually use crystal violet more. So that is another type of the dye that will enhance the surface pattern. And of course, in different settings, sometimes we will use non-absorptive dyes, such as the indigo carmine, especially if we are doing the inflammatory bowel disease cases, then we may want to just highlight the elevation or the polypoid lesions, then we will use the non-absorptive dyes. So this is the basic settings of what is called the image enhanced endoscopy. But of course, in the interest of convenience and time, we nowadays will stick to the virtual one more. But I think we all need to know what we are doing it for the image enhanced endoscopy. So before doing an ESD, first of all, we need to detect the abnormal lesions. So when we do the screening endoscopy, we still need to detect the abnormality before getting a ESD to do. So make good use of diagnosis is very important. Secondly, if we detect something, of course, we need to ask whether this is a cancer or a non-cancer. So this is very important again. So because before taking a biopsy or not, we need to determine this. Then if we decide that this is a cancer, the next question we need to ask, as Uedo Sensei mentioned, we need to determine the stage. Endoscopic staging is very important because we will then make the decision whether we should refer this case for surgery or we should do the endoscopic resection. So using these image enhanced endoscopy is the main aim is to achieve all this. Make the diagnosis of whether this is a malignant or not. Then if this is a malignant lesion, we need to determine whether this is a mucosal lesion or a submucosal lesion. Then it will. So this is all the basic steps. And we and for the endoscopy section, we need to know two major things. First is the margin, whether we should of course the lateral margin and also the deep margin. And actually the deep margin will then bring into the second important prerequisite is there's no lymph node metastasis, because if we do the endoscopic resection, most of the time we will then need to determine whether there's risk for lymph node metastasis to achieve something called curative resection. So these are the three major concepts that will be very important before sending a patient for endoscopic resection. Is first whether we can achieve an en-bloc resection. Secondly is whether we can achieve a margin clear resection, out-log resection, and of course we hope to achieve a curative resection, because after all, if you perform the endoscopic resection and turn out this is a deep cancer, the patient will still need surgery, so you are not helping at all. report. So these three are the most important concepts. So again, these are the explanation of these three terminologies. En bloc just meaning remove it in one piece. So most of the time it can be done. But more importantly is whether we can achieve the margin-free resection. So this will be the second important tier. But the third tier is the curative resection. So for making good use of the IEE will help us to make sure that we can achieve this before sending the patient for endoscopic resection. So when moving to the lower GI tract, so the colonic polyps, we have some important concepts or important parameters that we need to document it in our endoscopy report. So these five are actually the basics of the description of a colonic polyp. If you are referring a case for endoscopic resection by yourself or to another one, so you need to make sure you document all these five important parameters in your report so as to help the planning. First of all, of course, is the location. So whether this is located in the right colon, left colon, very important because it may affect the choice of the endoscope. And secondly, of course, is the size. So a very accurate size estimation will be very important. Although there may be some dynamic changes depending on the insufflation of the colon, which is quite different from the upper GI tract. The colon will move with the degree of the insufflation, but I think sometimes in the colon, we can make use of some additional equipment to help us to gauge the size. And thirdly is the morphology. So a very important issue for this because it will also signify the risk of invasion. So the morphology description very important. And lastly, of course, is the surface pattern and the vessel pattern, which I will cover more in the later slide. So these are the five key things that you need to mention. So for morphology, as I mentioned before, so in the colon, we typically will use this Paris classification. So I'm sure you all know this already. So for polyp lesions can be further divided into 1P or 1S, pedunculated or sessile. But for non-polyp lesions, so we will also look for any depression. If there's any presence of depression in the lesion, it actually signifies a high risk for submucosal invasion. So make sure that you detect that earlier and also mention that. And sometimes the lesions can be kind of like a mix. So can be like elevated at the edge and depressed at the center. So usually we will mention both features by telling the first parameter as the predominant type. So let's say if this is elevated in the edge, I will say this is a 2A plus a 2C in the center. So the second thing will be the minority, but this is very important to mention that as well because it will affect the treatment strategy. And sometimes we will, in the colon, we will see something called the lateral spreading tumor. So not the classical tumor. So those are the polyps that will actually in a horizontal manner rather than a vertical manner. So we also need to know these four nomenclatures to document that in the report. So in principle, you can divide the colonic lesions or the LSTs into two major types. So the granular types is the and also the non-granular type. So these two are the major categories. But then if this is a granular type, you also need to determine whether there's any predominant nodule. So the left side is what we call the homogeneous LST. So essentially all the granules looks the same. So in fact, you can see that this type of lesion is the most benign according to a histology correlation. On the contrary, if you can in fact see the if you can in fact see the prominent nodules in the granular type, in fact, most of the time the malignant foci will be in the predominant nodule. So sometimes we will make sure that if you are not too sure whether this is a cancer or not, you can actually take the biopsy at the predominant nodule, as it won't affect the subsequent endoscopic dissection too much as well. So these are the granular types. But for the non-granular types, it means there's no elevation component. So the whole lesion is a flat lesion. So the non-granular type, it is very important to determine whether there's any depressed areas. If there's a depressed area in the non-granular type, you can actually see that there are nearly half of them having some covert malignancy. That means it harbors some malignant cells inside. So this is very important to take note of this. So we usually in the screening colonoscopy report, if we detect any LST, we will further describe the lesion in one of the four these names here, so to guide the subsequent treatment for the advanced endoscopists as well. Then after the usual endoscopy, of course, we will go for the image enhanced endoscopy. And typically in the colon, it's very useful to use the NDI or the virtual chromoendoscopy. So I'm sure you all know this already. This is the nice classification in the colon. So classically, it distinguish three types of lesions. So on your left is the lesions that look very whitish on the NDI, because it is actually signifying more the hyperplastic polyps. So essentially the color and also the vessel patterns will help us to differentiate. And on your right, obviously you can see the whole thing is quite irregular and also with some central depression as well. But then the most important feature to determine is the surface pattern, whether this is destructed already. If a lesion has destructed surface pattern, most of the time this is an invasive cancer. So this can kind of help you to make a crude diagnosis. So just a quick illustration on how to make a quick diagnosis. So essentially the hyperplastic polyp will look nearly the same as the background mucosa. So it looks pretty whitish, while on the right hand side is the adenoma, so you can appreciate the difference. So the lesion will look quite dark because of the increase in vessels densities, and then it will look differently under NDI. And also hyperplastic polyps will usually have not much vessels or minimal vessels around the lesions. So it also again is classical for hyperplastic polyp. And for adenoma type lesions, the vessels will be quite kind of like thick and brown, but still it's regular type of the vessels. So this will be the adenoma. So the third thing that you can help you to differentiate is the surface. So for the hyperplastic polyps, usually the surface patterns will be quite whitish, I would say. But for the adenoma type lesions, the time will be more and also oval-shaped, depending on this underlying pathology. But most of the time, it will be kind of like a circular or oval shape to quite different from the hyperplastic polyp. So essentially, you can look at the color, the vessel, and the surface pattern to help you decide. Because if you determine this is a hyperplastic polyp, you can leave it inside you. But for adenoma type lesions, you should remove that. But sometimes it's very hard to further differentiate that by using the NICE classification, because an adenoma can be a high-grade adenoma or a low-grade adenoma. So recently, not very recently, but I think we are moving towards to the era of a JNET classification in the colon. So in fact, this can be applied to most of the time rather than the NICE classification, which I would say too crude. And essentially, the type 1 and type 3 lesions are just the same as the NICE classification. So essentially, the type 1 are the whitish and also hyperplastic lesions, while the type 3 are the irregular and disrupted. But what is added here is the type 2B and type 2A. Type 2A are actually the classical NICE 2 lesions. So essentially, the oval shape surface pattern, thin and brownish vessels. But what is added here is the type 2B lesions, because sometimes, especially when you evaluate those large polyps or the lateral spreading tumors, there may be areas that will signify a potentially high-grade lesions. So you can probably appreciate the difference between these two. So for the type 2B lesions, you can see that the vessels are indeed thicker and not forming a very regular loop again. So these are actually the features of a type 2B lesion. But you may say that sometimes it may be very difficult for one to determine whether this is a type 2A or a type 2B, or sometimes you can't even say whether this becomes type 3. So in fact, if you determine a lesion can be potentially type 2B, then or in between, whether this is a classical type 2B or a type 3 cancers, then we will use dye-based chromoendoscopy to further determine that, because we will have a better look of the peat pattern, or what we call the surface pattern. So Professor Kudo also proposed this Kudo classification. I think this will be typically applied for the chromoendoscopy right after the JNET classification. So this will actually highlight the surface pattern in a much clearer manner. So for my practice, I will usually stain the lesion with a crystal violet with a spray catheter, and also just a small amount of crystal violet, and then you wait for 2 minutes, then the surface pattern will then be highlighted. So you can see the usual crypts. If the lesion is actually normal, then it will appear just roundish. But if the lesions become more dendritic-like or gyrus-like, then it's more suggestive of a tubulovillous lesions. But if you can't see any structure patterns at all, then it may signify a cancer, in fact. So these are the real situation. So the peat patterns highlighted by the chromoendoscopy here. So the type 1 and type 2 are the very typical non-neoplastic patterns. So it will show the crypt openings very nicely. But if we move towards the type 3 or the type 4, you can see the oval shape or the gyrus-like surface pattern highlighted here. So these are still what we call the adenoma, or at most tubulovillous adenoma. So these are benign. But if we see something like this, so the surface pattern are no longer in structure or no longer in organized manner, then we really need to pay a careful attention. Especially, we need to determine whether this is a type 5I or a type 5N, because these two will actually lead you to totally different treatment strategy. So for 5, you can still see the although it's kind of irregular, but you can still see the organized manner of the surface. So it consists of both large and short crypts, and also the long type or the oval shape type. So kind of irregular, but you can still see the crypts. But at the below, this is the type 5N patterns. You can actually see some areas without any surface pattern at all. So these are actually a classical signal of a deep submucosal invasion. So if you see these patterns in the colonic lesions, probably is not suitable for endoscopic resection. So we may in fact take a biopsy and place a tattoo and refer for surgical resection. So very careful evaluation. And I also want to mention that is in the colon there are something quite different. It's called a sessile serrated lesion. So classically it looks pretty similar to hyperplastic polyp, but then they have some individual or the classical characteristics that will hinge to make a diagnosis of SSL, because this will actually turn into cancer on the contrary of the hyperplastic polyp. So when you see a nice one lesion or the JNET1 lesions, not necessarily this must be benign. So you should look for all these additional features to determine this is whether a hyperplastic polyp or SSL. So typically these lesions can be very flat, but SSL tend to locate in the proximal colon more. But for SSL, it will actually have a more something called a mucus cap, and also the classical pattern is the type 2O patterns. I will elaborate that later as well. So you look for these features to determine that. So what I mentioned here is the type 2O patterns is that you can actually see that the opening of the crypts are quite different from the normal glands. So for normal glands, you can see they are kind of like very regular in a cross or in a shape. But for the type 2O patterns, you can see the crypt opening are actually enlarged. So classically, they are no longer the normal looking type 2 patterns. So usually if you see this will be quite specific to SSL. So for if you see a JNET1 lesions with this type of type 2O patterns, you probably should still reset it, despite this is a small size or anything, or it looks like JNET1, but still, if you suspect this is SSL, especially if this is in the right colon, then you should go for endoscopic resection. So this is kind of summarize what we make the classification of this particular type of lesion in the colon. So first of all, if you see a lesion, then of course you will classify it according to the NICE or the JNET classification. If this is falling into the category of a JNET1 or NICE1, then you ask yourself for these questions, whether the lesion has any clouded surface, meaning the mucus cap, and secondly, the border, whether this is distinctive or not, and also the shape of the lesion, whether this is regular or irregular. And lastly is the crypts, the type 2O crypts or pit patterns. So essentially, if there are these features you may worry about SSL, then you should not leave these in situ. So after making all this diagnosis, we will then determine how to reset the lesion, because after all, we have so many tools in the colon now. So what type of endoscopic resection we should do? But first of all, we need to answer this question is why and when we will do an endoscopic resection. So typically for low-grade adenoma or the SSL, it's very easy to do endoscopic resection with very minimal risk of lymph node metastasis. But if we are targeting something called the early cancers or the lateral spreading tumors, it is very important to determine the equation. So again, we go is to the chromoscopy determine the Kudo classification, and should be able to predict whether this lesion is a deep cancer or not. So if you predict this is a superficial cancer with very minimal risk of lymph lymph node invasion, then you can still consider endoscopic resections. Then for the types of the endoscopic resection of the basic one and the advanced one. So for basic ones, we have the cold polypectomy now, and in addition to the traditional hot polypectomy. But for the advanced one, we have something called the EMR. We have many modifications now, apart from the conventional. We have underwater EMR now, and we also have pre-cut EMR nowadays. And of course, for larger lesions or more invasive lesions, we may go for the ESD. So, but we need to know when we will use each type of these removal device. So for now, I think this one is still very popular, the cold biopsy forceps. But in fact, there are data showing that there are a lot of incomplete resection using the biopsy forceps alone. So in fact, the ESD guidelines also recommends we should not use this unless this is too technically difficult for cold snares. And in fact, the hot forceps polypectomy is recommended against now. So I think nowadays we should move away from the use of hot polypectomy because of the risk of incomplete resection and also the risk of the delayed bleeding. So forceps polypectomy nowadays should be kind of like the last resort for those really small polyps now. But I think we all should master this is the cold snare polypectomy. So this will result in a better complete resection rate. So this is actually the first line treatment for those below 10 millimeters. And also, I would say the superficial adenoma. So whenever you see a lesion, despite the small size, you should still make a MBI, at least an MBI examination to determine the type of the lesion. And if you determine this is a low-grade adenoma, then you can think about the cold snare polypectomy. And nowadays, we should use this type of dedicated cold snares because it's a thin wire than the traditional snares, so it can result in a higher complete resection rate according to the different literatures. But what I want to mention, the limitation of cold snare is that it only remove the superficial layers mostly. So there are two studies comparing the use of the cold snare, hot snare, and also underwater EMR in removing different layers. You can see that if we look at the submucosal layers, in fact, the cold snare polypectomy is very weak to remove the submucosal layer. Only 30% of cases can get the submucosal layer. So there's a risk of called the incomplete resection of a deeper layers, especially if we see this. So this may not be an issue for low-grade adenoma because after all, for low-grade adenoma, this is just a superficial and mucosal lesion. But if the lesion is a deeper lesion, let's say it's a high-grade adenoma or even an early cancer, so if we use cold snare polypectomy, we will result in incomplete resection. So the key message here is, again, even if you see a small polyp, don't necessarily think this must be a low-grade adenoma. You should still do the standard NBI examination to look at the patterns, and if this is determined, let's say like this case, is determined to be a higher grade lesions, and in fact after staining you can probably see a type 5 eye patterns here. So in fact this is an early cancer. So if you use cold snare polypectomy here, you will end up as an incomplete resection. So these lesions should be removed by more advanced technique, at least a EMR. So this is kind of like the summary of the current treatment algorithm. So cold snare polypectomy should be the first line treatment for small, non-invasive, and also if you encounter dilated polyp, I'm sure you all know that we should use a hot snare polypectomy or a fixed. And of course, pre-treatment with endoloop is recommended as well. So again, hot snare nowadays should be reserved for the pedunculated polyps. You may actually, there are some groups also investigating the use of cold snare in these pedunculated polyps, but it may end up with a lot of immediate bleeding. So in fact, I personally will still stick to hot snare for pedunculated polyps. But what's more relevant to the talk today is how about those larger ones, the larger lesions, more than 10 millimeters, and also non-pedunculated lesions. So this is where we should carefully examine these lesions to rule out, first of all, rule out any deep invasion, and then we select the choices. So in fact, the treatment algorithm is not that difficult in the colon. So in fact, if you determine this lesion is a JNET2A or what we call a low-grade adenoma, then we can go for the simple techniques. So either use a conventional EMR or underwater EMR, which should try to achieve an en-bloc resection. But even if you unluckily get a piecemeal resection, these lesions are still okay if you determine this is a low-grade lesion. However, if the lesion is thought to be a higher grade lesion, JNET2B, or even after the chromo staining, you determine this is more like an early invasive cancer, then don't go for piecemeal resection. These lesions must be removed en bloc. So if the size is smaller enough, like within a snare size, you can still think about an en bloc EMR. But if the size exceeds, these are the best case for EM colon. And of course, in the rectum in particular, because these will be leading to a stoma and for surgery. So a very careful risk strategy. And of course, if you determine this is a deep invasive cancer, the nice JNF3 or those with type 5N, then probably we should do a proper staging and refer to the surgeons. So this is trying to summarize the difference between the EMR and ESD, which to go for which. And first of all, we really need to determine the degree of invasion of the lesions. So if you see something just JNET2A or the 2B lesions with the classical type 3L or the type 4 patterns, then these should be the good lesions with the low risk of SM invasions. And of course, for lateral spreading tumor, if you see a homogeneous granular type, this is also a very good case for EMR, even for piecemeal EMR in some and for these lesions, if we go for EMR, then we also will determine the size limit. So for any size limit below 2 centimeter, we can consider the conventional one. But you know that there are limitations of the snare size. So, but nowadays we have some modified techniques for EMR, which is called underwater EMR. The beauty of this technique is that under the totally deflated lumen and also feeling of the lumen with the clear water, the lesion will actually shrink. So the size will become apparently smaller than it is. So the snare can still capture the whole lesions. And also it will actually move the lesions, or what we call a floating effect, is move the lesions away from the muscle layer. So good for both the resection margin and avoidance of complications. So in fact, the randomized trial also the convention under for this type of intermediate size of lesion. You can see that the underwater EMR can achieve a higher en-bloc and out-lock resection than the conventional one. So a very good technique to be mastered, in particular for these intermediate colonic lesions. But if we are talking about larger lesions, that means those lesions more than 3 centimeters or above, and in particular, if you suspect any superficial SM invasion, this you see the JNET2, you may see some pattern or lateral spreading tumor with a prominent nodule in the granular type, or you are talking about a non-granular type lateral spreading tumor, these lesions should be removed en bloc and probably these are the best candidates for ESD. And of course, you need to make sure there's no sign of deep invasion as well. So ESD should be done in these cases, larger size and also supposedly deeper lesions. So in the last part, just some case sharing to illustrate the use of the chromoendoscopy or the IEE to help the treatment. So in fact, this lesion looks pretty small, maybe at most 1 centimeter. So some doctors may directly go for cold snare, but if we just press one more button, if we use the MBI, we can actually see the abnormal vessel pattern here. So it's very thick and irregular vessel pattern. And in fact, after removal, this is actually a high grade lesion with superficial or actually T1B cancer. In fact, you can see the size is just 8 millimeter, but in fact, this is a deep lesion. So it should not remove simply by cold snare polypectomy. So make sure you examine each polyps, even if this is small, by MBI. And then this is another case referred from another hospital for consideration of ESD. Probably they see the size, but in fact, if you look at the white light, you already sense there's some kind of irregularity on the surface. And in fact, if we examine the MBI closely, you can clearly see this is a JNF-free lesion. So we did not proceed with the ESD. In fact, we refer this case for a surgery, and in fact, it is a T3 cancer with metastatic lymph node. So this illustrates the importance of the triage at your index endoscopy. And also, this is a recent case referred from another hospital for consideration of ESD again. So at the white light examination, you can see a kind of like a 1S+2C lesion, so with some central depression. And in fact, if you use magnify MBI, you see some irregular vessels at the surroundings, and also the surface pattern is quite abnormal. But I would still struggle between whether this is a JNF2B or a clear JNF3. So in these settings, chromoendoscopy will help. So I did the crystal violet staining here. So in fact, especially on the right-hand side picture, you can see there are areas with the absence of the pit pattern. So essentially, this is a type 5N lesion. So we did not proceed with ESD again, and we refer this for a surgery because we think this will be a deep lesion. So just some simple take-home messages is first is always perform IEE before polypectomy. Even this is a small lesions, because it will help you to first predict the histopathology and then guide you for the best treatment. And secondly, this is kind of like a summary, although there must be some individual variation, but the general algorithm is that if we see a pedunculated lesion, most of the time go for hot snare, but if we see sets out or flat lesions, then we need to determine two factors. First is the size, secondly is any invasion. So if both absent, then very safely for cold snare. But if the size is larger, even with a superficial invasion, then go for ESD. Anything in between, you can consider EMR or underwater EMR. But if you see any deep invasion, then you should consider referral to the surgeons. So just a advertisement time. This is the NBAC book. So a lot of good case sharing in this book. So you can consider looking at this book for more details for the image enhanced endoscopy. So with that, thank you very much.